Good morning, everybody. Thank you for coming to the May Survivorship Lecture Series. Today, Dr. Mary Ziccardi Rodriguez, who is an assistant professor of clinical medicine in the Division of Cardiology at UIC, will be speaking. She earned her MD from the Universidad de Central de Venezuela. Sorry about that, Mary.
No
Completed
worries.
residency and chief was as a chief resident at Albert Einstein in New York and trained here at UIC as a cardiovascular fellow. Now she's the associate program director for the Cardiovascular Medicine Fellowship and the director for both the heart failure section and the cardio-oncology program. She is an active member of the Chicago Citywide Cardio-Oncology Society, where she collaborates with regional experts to advance multidisciplinary care and research in cardio-oncology. So today, she will talk about the importance of cardio-oncology in cancer survivors. So, Dr. Ziccardi, whenever you're ready.
Okay, thank you, Debbie, for that. Can you guys see my screen?
Yes, I think you need to go in presentation mode.
Can you see it now?
We can see it, but it's just hit
Oh,
present in Teams at the top right, or no,
let
it's
me
this isn't
see.
Teams meeting. At
Let
the
me try and
bottom
see what happened.
next to the Zoom slide bar, there's a little podium.
Yeah, I try. Oh, let me see if I can do that. Give me one second.
Maybe that one works.
Um, Let me see again. Give me one second.
Yeah.
Share screen. Okay, I'll do it this way and see if it works. Let's see. Can you see it now? For the presentation?
No,
No?
seeing it. I did before, but it just wasn't in presentation mode.
I'm sorry.
It's okay. We're letting other folks show up. Uh, Great. We see your screen now. Yeah, it's not wanting to go in presentation mode.
Let's see.
Does anyone know how to fix this as they used the PowerPoint on the web?
Let me see. Um,
Maybe if you go to the view
yeah, I'm trying to see.
next to help in the menu, maybe.
Oh, yeah, I see it. Let's see.
I
Okay,
know it's not optimal, but if you do want to send it to me, I can control it as well.
sure, that's fine. Let me see. I'm sorry. Okay, let me just try to do this quickly.
Sorry, everyone, for the technical difficulty delay. We'll
Mhm.
get going in just a minute. I swear it's going to be a great talk. While we're waiting, I'm just curious, do we have anyone from Rockford or Peoria here today? I think everyone's from UIC in Chicago. We should have tested it.
Sorry.
Does anyone have any announcements for the group while we're waiting for Dr. Ziccardi to get her presentation ready?
Do you want to announce the survivorship event?
Yeah, for sure. Survivorship event, I forgot what day we landed on, Dr. Tanshaw. I think it was the 21st, correct?
Yeah, I think that's right.
I think so. We are having our survive annual survivorship event. This is what, the third or fourth year, I believe. Um, and it will feature survivors' stories and really creating a narrative and celebrating survivorship heroes is our theme. It'll be at the School of Nursing. I forget what times it is. Do you recall, Pam?
I think it's 10 to 12. I'm looking right now. Hold on one second. I will tell you.
And Mary, I didn't get the attachment.
Yeah, 10 to 12.
10 to 12
Yep.
on the 21st.
Celebrating superheroes. Yep. Wear your superhero shirts.
Yeah. Can you drop that information in the chat for us, Dr.
I
Gansha?
sure can. Yep.
Great. Always a super fun event and great time celebrating survivors and everyone supporting them. I wish I knew. Is Ashley Sicard doing her lymphedema fundraiser again this year? Have you heard anything? Christina, might you know? Can't hear you, Christina. You're on mute.
Oh, sorry. I feel like my computer's running really slow this morning. Good morning, everyone. I do think that she is planning on doing it again. I don't have specific details, but I have heard that she is planning on doing it again. So that'll be very exciting. More details to come, most definitely.
Okay, great. We're looking forward to that.
Thanks
So,
for asking.
yeah, okay. I do have Dr. Ziccardi's presentation here. I'm just trying to pull it up. Let's see. Present. Okay. So I will share my screen. Just let me know when you need me to advance a slide.
Okay. Thank you. Okay. Good morning, everyone. Thank you. Apologize for the technical difficulties. But I wanted to talk to you about something that I'm very passionate about, that is cardio-oncology, to try to understand how the heart and cancer can relate and talk, and how we can help our patients to go through both conditions and try to keep the heart as healthy as possible. So you can go to the next slide. I have no disclosures. Next slide. And the objectives for today's talk is going to talk about the epidemiology of cancer and cardiac disease, take a look at the different cancer therapies and how these can cause cardiac complications, overview the radiotherapy and cardiac complications from radiation as well, and explain why we need cardio-oncology, how to stage those patients, and surveillance our patients who receive cardiotoxic treatment. Next slide. So just begin with what is cardio-oncology. So cardio-oncology is a multidisciplinary field that basically focus and try to manage cardiovascular conditions before the initiation of cancer therapies, during the treatment of cancer therapies, and after. And just because we don't want the cancer patient of today, to become the heart patient of the future, because like I mentioned, these conditions are kind of associated. Next slide. And the reason for that is because heart disease and cancer are the two top causes of death for both females and male currently in the United States. So this is very concerning, and we can kind of manage these two separately, but we should consider thinking about managing together because the associations of these two diseases and mortality is high. If you can go to the next slide, please. Additionally to that, we also know that currently cancer survivors numbers are increasing due to all the good therapies that we have nowadays. 64% of patients who are survivors, they have more than 5 years survivors after the diagnosis of cancer. 41% survive more than 10 years, and 15% have survived more than 20 years. And these numbers are going to continue increasing due to, like I said, advantage of all the medical therapies that we are able to do on these patients. And also something very important, that childhood survivors are 8 times more likely to die for heart disease and 50 more times to experience heart failure in their lifetime. And it's expected by 2040 that there will be over 26 million cancer survivors. Next slide. And like I mentioned previously, we are continuing increasing the number of therapies for hematologic and oncology cancers overall. So that also increases the chances for survival overall, but also increase of possible complications or side effects from these medications. Next slide. And like I mentioned previously, heart conditions is one of the most common cancer, not related to cancer, causes of morbidity and mortality in cancer survivors overall. So this is something very important because it could happen at the beginning of the therapies or even months or years later after the therapies. Next slide. And I have been mentioning, the patients who do not have cancer and do not have cardiovascular disease do overall very well, when you follow up through the years. But if somebody have cancer and have cardiovascular conditions, the mortality is very high. So their survival is also very, very low for these patients. So this is significant when you compare with the general population, or even when you compare with the patients who have cancers but do not have any cardiovascular conditions. Next slide. So I wanted to talk first about some overview of cardiovascular complications on patients, depending on the type of cancer therapies that they receive. Next slide. And, there's multiple therapies that can kind of target different cardiovascular tissues like the heart or the endothelial or the conduction system. So if we're going to cardiovascular, the cardiomyocytes have damage overall and then can develop heart failure long term. We have the anthracyclines that we are very aware of that, HER2 inhibitors, vascular endothelial growth factors, immune checkpoint inhibitors, protein inhibitors, and plaquettal cells, especially when they're mixed with anthracyclines. We also have an increased risk of coronary artery disease and atherosclerosis in patients who are receiving antimetabolites like 5-FU and capecitabine, that is well known and described to have vasospasm, but also endothelial dysfunction. Vascular endothelial growth factors and immune modulators can also increase your chances to have coronary artery disease. We also have increase of arrhythmias, very well known in routine to cause atrial fibrillation, but other medications like taxanes can also produce bradycardia. Anthracyclines is also very well known to cause atrial fibrillation and ventricular ectopies. This is like the mains that we normally use and we can see frequently. If you go to the next slide, please. We also have well-documented QTc prolongation in certain medications like anthracyclines. Like I said, they can cause multiple cardiovascular problems. But we also have endothelial growth factors inhibitors that can cause QT prolongation. And we just have to keep an eye on these patients when they're in therapies because, if we mix with other medications that can produce QT prolongation, we can go to ventricular arrhythmias. We also have certain medications like ponatinib who can increase the risk of peripheral artery disease. And other medications that can increase the risk of a stroke overall, like vascular endothelial growth factors related to hypertension, BCR-ABL inhibitors, and endothelial growth factors overall. Next slide. Additional to that, we have increased systemic hypertension in patients, but very well described vascular endothelial growth factors. When they're in these medications, the blood pressure turns to go up and then tends to go back to normal when we stop this medication, but it's still have increased risk to have, like we mentioned previously, a stroke and high blood pressure. There's also well-described proteasome inhibitors and BCR-ABL inhibitors to produce pulmonary hypertension. And going through thrombosis and embolic events, we know that cancer overall increase your chances to have embolic events, but also these medications like endothelial growth factor and immunomodulators can increase the chances for thrombosis. Next slide. So what does it mean to have cardiotoxicity in a patient who have cancer? So, I mean, the problem with this is we start some treatment. Unfortunately, the patient develops some type of cardiotoxicity, whatever it is. There's a concern that you will probably interrupt the chemotherapy. And then, this can decrease the chances to have some, curative effect of the medication or just control of the cancer overall. It also increases your physical morbidity and mortality secondary to cardiovascular disease. Like we know, heart failure is a very debilitating disease that is not going to let you, kind of move around, feel short of breath all the time. It also increases your mental health basically, because now you not only have cancer, but you also have a cardiovascular problem that is going to limit your chances to, have a good quality of life, but also to go to the treatment that it was going to help you. And it also can disqualify you from oncology clinical trials. So this is like very important for our patients overall, and I've seen it in clinic all the time. So we just have to keep a close eye on prevent these things to happen. Next slide. And this is how, cardio-oncologists, have a role in trying to help these patients, because like I mentioned, we have more new therapies and then increase the cancer survivors. But also cardiovascular disease remain the leading cause of morbidity and mortality in these patients. They have the patients who receive cancer therapies are increased risk of developing or have worsening of some cardiovascular conditions, like is very well described. That also just to have cancer overall, have increased inflammation, but just have cancer and get certain therapies, increase your chances to have acute myocardial injury and have an infarct. Like we also mentioned about the arrhythmias and all those stuff. So we want to prevent and have early recognition of these cardiovascular conditions for these patients to, improve their overall outcomes of the cancer therapies, but also to make these patients have a good quality of life and also increase their chances for recovery overall. Next slide. So I'm just going to mention for a case, it's a 61-year-old female who have mitocentric left breast cancer. She's estrogen positive, HER2 positive. She got a cytotoxic mastectomy, and she comes to the cardiology clinic. She was referred by an oncologist. She has not followed a cardiologist in many years in her prior reduced ejection fraction that got better. So just going to her past medical history, she had ejection fraction of 25%. That was very likely to be related to anthracycline induced. She got some ischemic evaluation, and that was negative at that time, and she didn't have any other reasons to have heart failure then. She got medical management, and her ejection fraction went back to normal to 55%. And I'm going to talk a little bit more about her oncology history later on, but she got diagnosis of breast cancer in 1999, and she got radiation therapy. She also had hyperlipidemia, hypertension, diabetes, and obesity. So all the cardiovascular risk factors that we, are kind of aware. She didn't have any congestion heart symptoms. She had a good functional capacity, and she was in good medical therapy with losartan 15 milligrams, carvedilol 12.5, Lasix 40, Spiral 25. Next slide. So going to her initial breast cancer diagnosis, she had less breast cancer diagnosed when she was 38 years old. In 1999, she got lumpectomy, radiation, chemotherapy. The chemotherapy was presumed to be 240 milligrams per meter square. The main side effect that she had at the time was like heartburn, and she was not eating well. And she was diagnosed with heart failure almost 10 years later, 11 years later. And then she was on medical management, and she recovered. Then in 2021, she was tested positive for a mutation in BRCA2. She was confirmed to have hereditary breast and ovarian cancer syndrome. She had follow-up surveillance with a mammogram that noted a suspicious mass in the left side where she had her initial cancer. And she was biopsy and turned out to be positive. She had bilateral mastectomy, and she was a stage of early breast cancer, early stage. So then she got adjuvanted chemotherapy, or the plan was to do paclitaxel 12 weeks of trastuzumab every 3 weeks, in 1 year, and then 5 years of aromatase inhibitor. Next slide. The slide on the, I guess on the left is cardiac MRI that she had when she had reduced ejection fraction. So you can see the two chambers of the heart, the right side is on the top and the left is on the bottom, and you can see how it's not squeezing completely well. So she was reduced around 35 to 40%. And then on the right, we have an echocardiogram with ejection fraction being better, and this is what she got recovered. You go to the next one, please. So what do we do with these patients? So the first thing that we need to do when we have somebody who are considering to do some cardiotoxic therapies, or I would say for any patient who have cancer overall, which is just kind of risk stratify, if they, what's the cardiovascular risk overall. So we always have to ask for like, if they have any cardiovascular symptoms, if they have any heart failure symptoms like shortness of breath, lower extremity edema, PND or topnia, what's their functional capacity overall, and if they have history of cancer previously, what was the medications that they were getting. And I will go into more details on that. We normally want to do an EKG just to have a baseline QTC, note if they have any arrhythmias, if they have any infarcts or something like that, that we can kind of, decide if we have to do further evaluation by that time. If they have any cardiovascular conditions like high blood pressure, hyperlipidemia, for example, they should be treated before we start any medication. And if they have some cardiovascular disease or cardiovascular toxicity from prior therapies, we should at least consider doing a baseline troponin and a baseline BNP with an echo, assess the left ventricular ejection fraction and the global longitudinal strain, and then refer to a cardiologist. Next slide. And this is kind of the heart failure international cardio society calculator. This is also like has been done. It's been used for multiple years, and this is kind of how we risk stratify the patients based on certain chemotherapies. And this one that I'm showing right now is for patients who are going to receive anthracyclines. So if they have and it can just give you a scoring system, and you can have high, medium, or very high risk first, and then you just basically add this. So if somebody have already heart failure with reduced ejection fraction, they put you in very high risk. If somebody have severe valvular disease, they put you in high risk. So you can start adding all these markers. I would say there's the stuff that already kind of increase your risk overall that you cannot change. They're not modifiable, like age. If you're more than 80, you're kind of medium, you have 2 points, but if you're 65 to 79, you're like medium 1 point. And you can see there's multiple conditions here that you can see in most of the patients who have late stage breast cancer, like when they're old, like perimenopausal or menopausal patients, just for example. Okay, you can go to the next slide. And just going back to our patient, she have hypertension, so that give her 1 point for median. She have obesity, another point, and diabetes, another point. So that's 3 plus 2 from the prior history and anthracycline. So let's give her 5, but just to have the previous history of cardiomyopathy put her in a very high risk. So she's very high risk to develop cardiotoxicity with anthracyclines or trastuzumab. Can you go to the next slide, please? And, I'm just going to talk about the most common ones that we use. And anthracycline is very well-known drug to cause cardiotoxicity, and we use it for multiple types of cancer, like breast cancer, leukemia, lymphoma, sarcomas, uterine and gastric cancer. And the way that it works is kind of go to the topoisomerase 2 and inhibit that enzyme, that kind of take care of the DNA double-stranded repair, but it binds with iron, and then it causes increase of free radicals species. So basically, by free radical damage cause apoptosis and damage of the myocardial cells. Go to the next slide, please. And we know that can cause clinical heart failure between 1 to 5%, but there's another thing that I think is also scary is the asymptomatic patients who have reduction of the left ventricular ejection fraction that goes to 5 to 26%. That is very significant. Toxicity can occur at any low cumulative dose. We know that there's no safe dose overall. Obviously, we know that certain doses increase your chances to have increased risk to have heart failure. And we know also that you can have different timing of the toxicity overall. So you can have early onset heart failure that happen in the first year. It will be 9% of the cases, but we know, and this is like I said, it's scary, that even later on, 10 years later, you can have 57% of having reduced ejection fraction. Additional cardiac problems that you can have is atrial fibrillation, the 8 to 10%. Most of the time will be in the acute setting, but it still can happen later on because of the fibrosis and the apoptosis that happen during the therapy. You can also have ventricular arrhythmias or QTC prolongation. Next slide. So like I mentioned, risk factors, cumulative anthracycline dose, you get a bolus dosing instead of like a steady dose. The stream of age, female sex has been described to have increased risk overall, but this is, I guess, also related to the cancer. Concomitant medicinal radiation, like, left breast cancer, you get radiation, you get anthracyclines at the same time, you increase your risk to have free radicals and get more apoptosis and fibrosis of the heart, obesity. To have a baseline elevated cardio biomarkers prior to treatment increase your risk because it means that your heart is already, like breaking down cells, just to put it that way. So you increase your chances that you're going to continue doing that when you have these stimulus from the free radicals and the anthracyclines. If you already have a left ventricular ejection fraction less than 50%, increase your risk because, like I said, your heart is at baseline not normal. You have pre-existing cardiovascular disease like coronary artery disease, hypertension, diabetes, smoking exposure, obviously, because also atherosclerosis. If you're getting cyclophosphamide, paclitaxel, and anti-HER2 therapies at the same time that you're getting anthracycline, increase your risk factors as well. And if you have genetic risk factors. Go to the next slide. Okay, so what things we can do to kind of prevent these cardiotoxicities to happen? Like I mentioned, continuous infusion reduce the peak plasma level of the anthracyclines overall, and it will decrease your chances. It's a little bit more protective, but there's limitations to that. It's not protective for pediatric patients, and we're not completely sure how clinically benefit it is. Liposomal encapsulations of the doxorubicin. They kind of prevent and reduce accumulation of this drug in the myocytes. But I have been told from other oncologists that it's just like too expensive and insurance sometimes doesn't cover, unfortunately. And the other thing that can be used is the dexraxosine. It's kind of an iron chelating drug. It can be administered at the same time with doxo. But there was some prior studies that kind of were concerned about the efficacy of the treatment when you were doing this at the same time. But it's just something that we can kind of use on patients who are getting a cumulative dose of anthracyclines and we're concerned that they can develop this cardiotoxicity. So it's just something that we can consider. Next slide. I'm going to HER2 receptors inhibitors. That will be like the next therapy for this patient. At least that was the plan. That is also kind of cardiotoxic. At least 20% of breast cancer tumors have these receptors being positive, and it's associated with worse prognosis. But we had the monoclonal antibodies against that as trastuzumab that kind of it changed the management of these patients overall with breast cancer. Can also be used for GI tumors who express the HER2 and it's expressed in the cardiomyocytes, and it's key to protect and kind of increase survival of the cardiomyocytes overall. Next slide. So the way that it works, it just increases cellular transcription factors, and it kind of protects like I said, for free radicals and all that. But if you're using trastuzumab and anthracyclines at the same time, the anthracyclines already told you increase your free radicals. It just increase your free radicals overall. You can not protect them and the DNA and all the stuff. So just basically causing more apoptosis, more harm. But it has been told that when you stop these medications, the HER2, you kind of have a little bit more of chances to recover than when you do anthracycline. So this is just something that automatically, if you put these patients on certain medications, increase your chances to recovery and not to have a more permanent cardiotoxicity. Next slide, please. And similar risk factors and risk assessment, like I mentioned previously, if you already have heart failure or cardiomyopathy or prior toxicity from HER2, or you're getting anthracyclines at the same time, you increase your risk to have cardiotoxicity. But very similar, like you mentioned from the prior one. And what do you do in those cases? You try to have a baseline echo in all these patients, and you want to do an echo every 3 months while you're in the therapy, and then 12 months after the therapy if you're doing it, adjuvant and adjuvant treatment. And then transthoracic echo for all metastatic HER2 disease every 3 months or in the first year, and cardiobiomarkers in high risk and very high risk patients, just to have it at baseline. Because if these change later on, if the patient's having any symptoms, it will help you to understand what was the baseline of the patient. Next slide. So primary prevention for cardiotoxicity. Next slide. So this is something that has been studied for a while, and I would say we still don't have a very good answer, but we're trying to understand a little bit more. And I have a bunch of studies here, but I would say most of the stuff that has been studied initially were beta blockers and ACE inhibitors or ARBs. And, like the Overcome study was using anthracyclines. Oh, and I would say all these studies are between breast cancers and lymphomas. And they're just a little bit different. But most of them are with that, and anthracyclines and HER2. So carvedilol kind of decreased the incidence of that and heart failure, but there was no change or reduction or decrease in left ventricular ejection fraction when used with enalapril. The product study was anthracyclines plus HER2 or HER2 alone. It didn't show any significant difference on patients who were taking metoprolol compared with the cardesartan, that there was decrease in the left ventricular and dimension and the systolic dimension on the volume. But there was a decrease, attenuated decrease on the global longitudinal strain. Global longitudinal strain is something that it kind of tells us like how small changes on the contractions of the myocytes overall it changed. So it's an early prognosis, or it just tell you early on before you have significant decrease of the left ventricular function of the heart. So it's kind of like a smaller change versus a more visual change of the ejection fraction that we look at the echo. Going back to another study using beta blockers like bisoprolol, there was attenuated decrease in the left ventricular ejection fraction with bisoprolol, and the Manticore study and the peridopril was also attenuated decrease of the left ventricular ejection fraction, but there was no difference in the left ventricular and diastolic volume. And then the Googling study was like carvedilol and lisinopril was actually showing there was cardiotoxicity-free survival overall on these patients when compared with placebo for both of them. And then we have the SAFE trial that was bisoprolol or bisoprolol and ramipril, and it shows that there was decrease of left ventricular ejection fraction that was actually less significant and unchanged global longitudinal strain when there was in the ramipril and bisoprolol. And cardiotoxicity was defined in most of the studies as a decrease of the left ventricular ejection fraction more than 10% and under 55%. That is quite what we call normal. So overall, what we have from the beta blockers and the ACE and ARB is it's helpful to have it on board if you have other conditions. But if you develop cardiotoxicity, they have some role in these patients, and we're going to use it probably on these people because this is what we do for patients who have ejection fraction. This is the medications that we use. And there was like hypothesized that carvedilol was better than the other ones just because of some anti-inflammatory effects. So that's kind of what we probably will try to go for, like carvedilol if we're talking about a beta blocker versus other type of beta blockers that we use for heart failure. Can you go for the next slide? And going to other medications like spironolactone that we use for heart failure, what it shows when we use anthracyclines, it was like a protection to decrease of the left ventricular ejection fraction, so it didn't decrease ejection fraction, but also protected to develop diastolic dysfunction. And this is because of the antifibrotic effects that spironolactone has. That's kind of what we use it for patients who have heart failure as well. There's some studies for statins. Like I said, we don't have like a clear cut, like if it will be helpful completely, except for the cardiotoxicity trial that kind of shows that it decreased anthracycline effect cardiotoxicity overall. But I would say we still probably need to have more studies, but it is helpful if your patient is already have other reasons to be on this, just to be on this medication, because theoretically it will help and prevent cardiotoxicity. We'll just put it that way. And then we have the SGLT2 trials. The Gongora study kind of shows that this was a study that was done just taking patients who were diabetic, who were on SGLT2s, who have cancer, and when treated with anthracyclines. So we still probably need more studies based on that. And it just showed that there was a decreased risk of heart failure, cardiac events, and overall mortality. But we don't really know like what left ventricular ejection fraction or anything like that. So we still more studies. And like I said, this is all heart failure medications that we use day to day. And they were just trying to use it if in these patients we're going to get cardiotoxic medications that can decrease the left ventricular function or develop heart failure later on. Next slide. And this is just kind of showing like if for some reason you were on certain cardiotoxic agents and you develop heart failure, or meaning that you have somebody who have reduced ejection fraction and have symptoms, or they have symptoms but they don't have significant reduction of the ejection fraction, maybe you can just consider minimize the use of cardiotoxic drugs. This is a class 1 recommendation, but then the use of ACE, ARBs, beta blockers, the dexrazoxone, liposomal anthracyclines, or even the statin is a class 2A. So the way that I see it is if you have another indication just say that you have high blood pressure, maybe just use, a beta blocker or ACE or R just to try to increase, the chances just in case, and you're also not causing any harm. Same thing if you can be on statin. So this is just the way that we see it, if we can, just to prevent these things. But if the patient already have some type of cardiotoxicity, it will be worth it to do it unless you have concerns for side effects or anything like that. Next slide. So going back to our patient, we increased our dose. We were deciding to do echoes every 3 months just to keep an eye on her. And we just have the decision with the oncologist to start the trastuzumab and continue the current cardioprotective therapy that she had. She already had reasons to be on it because of the reduced ejection fraction that she had before. So we just decided to keep it on. Next slide. And then we saw over time her, we were just keeping an eye every 3 months, where her ejection fraction went down at 12 months, and she was developing symptoms. That is like the most important thing. So we decided to stop the trastuzumab after 13 cycles. She felt better afterwards. She was able to walk a little bit more. Ejection fraction is still not perfect, was 45%. Next slide. And as you can see, she went from like normal on the right to reduce pumping of the heart basically on the left side. Next slide. So we continue, discussing with the oncologist how we want to manage this. We continue with some hormonotherapy, letrozole, and then we were just thinking to the neratinib adjuvant for a year after her ejection fraction went back to normal. And I saw her a couple of weeks ago, and she was way better. So that was the plan. And we will just continue keeping an eye on her cancer progression. Next slide. Something else that is very important is radiation therapy and cardiovascular disease overall. Next slide. I would say, 50% of patients undergo therapeutic radiation. Due to the increased survival and potential long-term effects of the radiation, we just have to keep a close eye on the cardiovascular toxicity overall. These patients have increased risk to have major coronary events like strokes or coronary artery disease like an MI. More than 10% have major cardiac events like heart failure or coronary artery disease in the first 24 months. But I would say most of the time, the side effects that we see could be even years later. There's due to the radiation, there's myocyte damage that can cause heart failure with preserved ejection fraction due to the fibrosis, and then this can progress to heart failure with reduced ejection fraction. And something that we rarely, another thing that we also see is like valvular disease. Like I said, it could happen years later. It could be restricted motion, or it could be, causing a stenosis, or it could be just regurgitation because the valve is incompetent. And pericarditis is another side effects that we see for radiation. I would say rarely acute, more likely later on down the years. It could be just basically restriction, the pericardium, basically because of fibrosis that can cause heart failure-like symptoms. Next slide. And this is just basically pointing out, like, if you're getting chest radiation, left-sided radiation, you can just develop any of the stuff because the heart is on the way. Unfortunately, I know we're getting better on these radiation therapies to try to protect the heart as much as possible. But it can also cause arrhythmias due to fibrosis of the myocardial itself, and even the conduction system, valvular disease, myocardial disease because of acute pleural fracture. So next slide. Okay, so potential cardiovascular effects of a screening tool. So I would say it's not only the heart, it's also all the vessels, depending on where you get the radiation. So you can have fibrosis, and you can have a stroke, you can have autonomic dysfunction because of the, the nerves that have been affected by the radiation, and thyroid dysfunction. So you have to keep an eye on the carotid, broad orthostatics, and we can keep an eye on those stuff, with the CT scans that we do to, basically screen those patients down the line, carotid ultrasound, thyroid. For thoracic radiation, they can have atherosclerosis, valvular disease, pericardial disease, heart failure. So we should do echoes, stress testing for these patients down the line, like maybe every 3 years, 5 years, or if they have any symptoms, obviously we have to do a further evaluation of that. And it can also cause abdominal and pelvic radiation, can cause aortic atherosclerosis, electrosclerosis, renovascular hypertension. So we just have to keep a close eye on the ankle brachial index and blood pressure monitoring for this patient. Next slide. Okay, so this is kind of just what do we do. Normally we should have a baseline echo, a baseline EKG, just have a very detailed physical exam and history taking. And then annually, we can just do, orthostatics, vital sign, auscultate to see if we have any carotid root, blood pressure in both arms, look for signs of superior vena cava obstruction or stenosis, and then every year, the carotid ultrasound on high-risk patients or the echoes every 6 to 12 months. And same thing for every 5 years. Next slide. So how to screen patients who got high doses of radiation over 30 grays with heart in the treatment field, lower dose if they were also exposed to anthracyclines, because it increased your risk to have those complications as well in cardiotoxicity. Patients who were less than 50 or they have radiation long time ago, to have a very significant cardiovascular risk factors to begin with, or any pre-existing cardiovascular disease. Okay, next. Okay, next slide. So how do the cardio-oncologists help with this? I mean, I would say, we just want to help. We just want to help the patient to be able to go through this. So we just want to maximize the cancer treatment and the cancer success, because obviously we want this for the patient, but we also want to minimize the cardiovascular toxicity and improve the overall outcomes. And we even have this concept called permissive cardiotoxicity. That is, somebody develops certain degrees of cardiotoxicity, and this is a treatment that is going to be the only option and curative. And, we just kind of like, okay, it's fine. Go for your cancer treatment. We just keep a close eye on you, because we understand how important it is. And we kind of have some tools to try to help the heart to recover. So we just want our patients to be able to be, everybody informed and be able to get through the therapies. And we don't want to discontinue anything unless, it's very risky and these patients can do very poorly if we continue with this. But our main goal is just to try to keep a good heart, so then the patient can go through this therapy and, survive and have a good life. Next slide. And that's the reason why it's so important to always have a baseline cardiovascular toxicity risk assessment before any therapy. And so that way we can know how to surveil these patients. Next slide. So that takes me to how do we help overall. So we help at the moment of the new cancer diagnosis, and we try to be very aggressive with managing the cardiovascular risk factors. And then depending on your overall risk, we can kind of, decide how often we're going to screen you. And if we have to refer you to the cardio-oncologist to begin with or not. If you're low risk, most of the time we don't do referrals, but moderate to high risk, we should be seeing these patients just to keep a closer eye on them. And then, after you complete the treatment, we will see you, we will do echo, we will just see how your functional capacity and go from there. And we can follow you through the years, because depending on the high risk of the developed cardiotoxicity, we should just do a kind of echoes like every 1, 3 to 5, and every 5 years after that. Or if you develop any cardiovascular symptoms during therapy or even after, will be good for us to see you, so then we can decide, what do we have to do with this patient and how we can manage to help them feel better. Next slide. And this is for patients who are cancer survivors. We kind of risk stratify them after they got therapy as well, just to kind of know how often we have to keep an eye on them. So if you have very high risk because you were getting doxorubicin more than 400, and you already have a very high baseline cardiovascular risk or toxicity overall, we should just keep a closer eye on you, versus somebody who have a low risk, who only had like some myocardial toxicity during therapy and low dose of doxorubicin. Next slide. And this is how kind of we screen. So low risk, annual cardiovascular risk assessment, we just keep an eye on you. If you develop any symptoms, you probably move to a different category, to a moderate risk. And you'll have to be seen by a cardiologist. And, if you have cardiovascular toxicity risk stratification after 5 years, and then we just keep a closer eye on how you're doing overall. We just do like the echoes, like I said, if you're a childhood survivor. We can just do it between every 5 or every 2 years, depending on your risk overall. And the other thing that is very important for this patient, if they're planning to get pregnant, it's a female who have, it's a childhood cancer survivor, we should keep a closer eye on these patients, because they have increased risk to have cardiotoxicity while they're pregnant. Next slide. And just more about what we were just talking about, childhood survivors and cardiac toxicity overall. I mean, depending on what they got, if they got cardiotoxic exposure, they had significant cardiovascular risk factors or genetic factors, they got radiation and anthracyclines at the same time, they have increased risk through their whole life to get coronary artery disease, heart failure, arrhythmias, valvular disease, or pericardial disease. So we just want to keep a close eye on that overall. Next slide. And something that I'm very passionate about is, cardiorespiratory fitness overall. And I would say this is like one of the most important things that we should do for our patients, beside managing all the cardiovascular risk factors. It's just the lower fitness that you have, your cardiovascular mortality overall will be higher. Compared to if you have high cardiovascular respiratory fitness, your mortality is actually, you have higher chances to have a better life and more survival overall. So this is something that we should kind of encourage your patients to continue doing. And if you go to the next slide, please. The other thing that is important is high intensity interval training improve the outcomes overall on these patients during treatment and after treatment. And I understand overall these patients might not feel good during chemotherapy, but it's just something to kind of tell them. And this is kind of what I do, just to tell them, like, continue going for a walk if you can, or trying to be as active as possible, because this is going to increase your senses. And I also wanted all of you to be aware that we have the cardiac rehab. People are very good about, trying to keep all these patients in shape if possible. We're working to try to get this like kind of insurance approved as well, but we also have a HIT program that it could be offered to these patients. It will have to be out of pocket, but it still is something that they can do if they're interested in it. Okay, next slide. So cardio-oncology referral, I would say patients who are like moderate to high risk, features before initiation, patients who have a normal screening test for the testing of cardiovascular treatment optimization before the therapies, patients who develop any cardiovascular symptoms after cancer diagnosis or might be related to the cancer treatment, and cancer survivors with chest radiations. And I would say overall, because also these patients get endocrine therapies, like hormonal replacement, hormonal therapy, these patients should also be screened by the cardio-oncologists or cardiologists overall, just because they have increased risk to have, metabolic disorders, diabetes, hyperlipidemia, and then increased risk to have coronary artery disease. Next slide. So take-home points. Patients with diagnosis of cancer have an increased risk to develop cardiovascular disease through their whole life. Cardiovascular complications associated with cancer therapy are more prevalent, and as more therapies are developed, more of those will happen later on. Early detection of risk factors, try to cure as early as possible, to limit the development of cardiovascular disease, are very good for patients and increase their survival and, quality of life. More studies are needed to understand cardioprotection in these high-risk patients. And, cardio-oncology as a field is growing very quickly, and we're still learning how to manage these patients together with oncologists. But this is something that we just want to offer to our patients so they can do better. And multidisciplinary strategies to manage this group of patients is necessary to improve the overall quality of life. Okay, that's it. Any questions?
Thank you, Dr. Ziccardi. That was wonderful. That talk, I feel like cardio-oncology is so much more intricate and so much more to it than we think about and we give it credit for. So thank you for walking us through all that, especially screening pathways, I think, and what we should do for long-term screening for these patients is something that we discuss a lot in clinic. And so thanks for going through that and helping to clarify that a little for us. I do want to make a comment. I know there's so much about anthracyclines, right? And other types of chemotherapy medications that cause cardiac toxicity. I actually have a patient I'm seeing soon who is on a clinical trial of carboplatin, docetaxel, and Keytruda. Do you have any thoughts on that regimen? And if there would be cardio, or I would imagine it's to avoid some of that cardiotoxicity of the anthracyclines.
Yeah, it sounds like, it is likely to be. But like I mentioned, you have to have kind of your baseline cardiovascular risk to kind of figure out which patients are going to develop or not. I mean, if this person had cancer before, they got something similar, obviously increase their chances. But I would say that regimen sounds like could be cardiotoxic. But like I said, you just have to kind of risk stratify everyone, so then you can decide. Yeah. But I would say baseline, EKG, echo, and cardio biomarkers will be the first thing. Be very careful about what's the functional capacity to this patient to begin with. and that's something that is very hard for us sometimes to even like manage, because sometimes we don't know it's just like something cardiac related or is the cancer itself, because they might not eat, they might not drink. If they have lung cancer, also make it tricky. So it's very good to be able to have those things very well documented, so then you have some ideas how was the functional capacity to begin with.
Right. Yeah, we need to be checking all our survivors that we have a good baseline in that case for sure. Does anyone else have any comments or questions for Dr. Ziccardi?
I can ask a question. I missed the initial introduction because I was having audio issues, so I may have missed it. But other than therapies causing cardiac toxicity, are there any other pathways by which cardiovascular health is related to cancer cells in the body?
Yes, there is. I always say they kind of talk to each other, kind of thing, just put it that way. Like people who have heart attacks has been shown that maybe later on they might develop cancer. And it's just, it makes weird, right? Like, it just, why a heart attack will cause cancer along the way, but it's just like inflammatory pathways and common pathways. That's the other thing, right? Like, there's certain cancers that have some risk factors that are also cardiovascular risk factors, right? If you have perimenopause, a woman, and you're obese and you're smoking, you have hyperlipidemia, all the stuff, you increase your risk to have breast cancer down the line. So it's just both of them, they are related, and we believe it might be some inflammatory related or some immunity, some immune system not be able to detect cancer cells and stuff like that. So we're not completely sure, but there's some evidence that some factors between the cancer and the cardiovascular disease overall can communicate to each other and cause those things like tumor growth factor, TNF alpha, increase your chance to have inflammation overall, and also increase your cardiovascular disease when you have a big tumor, just to put it that way. So people who have advanced metastatic, like breast cancer, for example, you have increased chances to have pro-inflammation, have atherosclerosis, and have heart attacks. And the same way for the heart, like I said, when you have acute heart attacks, your chances in the first couple of years are to develop some type of cancer or just to have diagnosis of cancer down the line is actually higher. So it's quite
That's
interesting. We're still
interesting.
learning.
Wow, so it's really bidirectional.
Yeah. There's a very nice paper in Nature. Came, I think it was like a year ago or 2 years ago. That kind of say like how, like I said, cancer and heart kind of talk and kind of, it's just like signaling thing, but how can be related both of them multiple ways. Yes.
Oh wow, I'm going to look up that paper. If you can drop it in the chat, that would be
Sure.
very helpful, but that's okay. I can look it up too.
Yeah,
Thank
I
you.
can find it. But it's quite interesting how the two of them are very related. So yeah, it's called crosstalk between breast cancer and ischemic heart disease.
Okay.
That's so interesting. So, like I say, this just it goes very deep, like in lots of different pathways for the heart to interact with cancer that we don't talk about enough and think about, off the top of our heads. So, Sonia Williams, the director of Cancer Health Equity at Wellness House, asked a question in the chat. She said, "Thanks for being here today. Do you refer to the community? For example, Wellness House provides nutrition, yoga, exercise classes for cancer survivors. So, maybe do you incorporate Wellness House for your patients with cancer?"
I mean, I didn't know about this, but I will, if I will definitely do it. I would say like, yeah, I have patients who have like a heart failure related to anthracyclines, and I have seen how they're overall not, doing well for multiple reasons, like nutrition, like you were saying, or like even like just their mental health. I feel like, they just went through so much, but I will do that. I will refer those patients. So thank you for that resource.
Yeah. Do you want a connection? I can,
Yes, please.
great. I will email you and Sonia to get you connected so that those resources, because we refer our patients in survivorship to Wellness House resources all the time. So that would be a great thing to collaborate with. They work in the OCC too and at Mile Square.
Okay, good. Thank you so much.
Great. Dr. Ganshow, our fearless director of prevention and survivorship, any comments? She may be away, or if you are talking, Pam, you're on mute. But well, thank you again for a wonderful talk, Dr. Ziccardi. And yeah, if no one else has anything further, I know some of us need to get going to 10 o'clock meetings. So we'll see you here next month. Thank you all very much for coming. Bye.
Thank you, everyone.